Good afternoon. Thanks for joining us. We're here to talk about successful phone screening. Thank you for joining us on the phone. We're starting a new format with education, so we hope that all of our technical difficulties are done and that you all can hear us on the phone. If someone could just enter in the question box that yes, you can hear us loudly and clearly, that would be helpful. It's Julie Barney talking right now. We're welcoming you to our annual phone screening refresher. And we're going to ask that you hold all of your questions till the end, just because it's very difficult in the room and on the webinar to address all questions if we're talking at once. So we're going to answer your questions at the end. However, we did build in questions throughout the presentation as polls. So we're going to ask anybody joining us on the webinar to answer those questions as they come up during the presentation. But if you have specific questions for our presenters, we're going to ask that you hold those questions until the end. That being said, we do have contact hours available for this session. Some housekeeping items with that. To be eligible to receive a contact hour, you must sign in either in person in the room here or in the webinar under the question section of your webinar. If you could enter your name and your practice, if you're listening as a group, list everybody who's in the room with you. Thank you for joining us as a team.
Oh, you're fine.
And then you're going to attend the entire session. And then there's an evaluation that is electronic that will follow this session. That's a SurveyMonkey link. So if you would like, you can take a screenshot of this particular slide. You will also be able to see this at the end of the presentation. You can jot it down. This is how you will complete your evaluation. You have 2 weeks from the, you will have until the 15th of January, so roughly 2 weeks, to complete your evaluation. And then we will send you your contact hour, inter-office mail or by email, depending on how we're able to get that out to you more efficiently, in 2 weeks from the 15th of January for this particular session. So you do your evaluation, and then a couple weeks after that, you'll receive your contact hour. Without further ado, I'd like to introduce Jared Karen, who's going to start us off today talking about phone screening.
Good afternoon. Thank you, Julie. Welcome, everybody. We want to thank you all for attending this afternoon, supporting this. We are excited to offer this annual phone screening refresher course. Couple of quick additional housekeeping pieces. I do want to welcome everybody who's joining us by phone through the webinar. That is something that we are a little bit new to, so forgive us if we do have some snafus with that. We're still getting used to the technology. But we're happy we're able to deliver it to you that way. A couple of things for those of you in the room. There are microphones on this table, so anything you do is, to some extent, people can hear you on the phone. So just be careful about shuffling papers and things like that. It can be very distracting if we're not careful about that. But at the same time, when we have our discussion components, it will be helpful to speak up a little bit so that the people on the phone can hear your responses as well. So we're really excited about this because this is one of the first times we've been able to offer a specific course for medical assistants, and we're really happy we could do that. That's the product of some extensive development we've done into the content here. If you recall, in the past we've tried to teach everything you needed to know about triage and phone screening in one session once a year, and we've determined that that may not be the best way to do this. We appreciate that the interaction we have with patients over the phone is complex. There's a lot of nuance to it, and so we want to honor that by giving you really good content, even if we have to do smaller chunks of it at a time. So if it seems like I'm not covering things or we're not covering everything to do with phone screening, it's because we're not. So we are bringing that information to you in the future. We have extensive plans for 2019. We're going to bring a lot more options for learning about phone screening and triage. So if there's something we don't cover today, don't worry, stay tuned, we're bringing it to you. So we are going to focus on one very critical, important aspect of phone screening today. So that is going to be our focus, but we're not forgetting about those other pieces. We'll give you a little tease of what that may look like as we go forward. So I also want to introduce you to my fellow presenters. I am joined by Amanda Diamond, our nurse preceptor, and my fellow educator, Lisa Lang. And if you guys would just say hi so people recognize your voice on the phone.
Hi. Hello.
First one with Amanda, we'll start with Lisa. So let's actually look at what we're going to talk about today. Julie, can you hold up the PowerPoint first so that I can switch slides? There we go. So we're going to begin this discussion with some definitions. We're going to define telephone triage and phone screening, and talk about how those two things may be a little different from each other. We're also going to look at the objectives of each of those processes because they're a little bit different. And we'll also have a discussion to generate some awareness of appropriate scope of practice. So we'll be talking about what is appropriate scope of practice for all the different levels of licensure so that we're all comfortable with what we are capable of doing and allowed to do by the law. So we're then going to transition into nuts and bolts. How do we do this well and effectively? We're going to revisit that goal and objective of phone screening so that we can keep that in mind as we go forward with doing it. We'll give you some tools that you can actually take back to your practice this afternoon and start using right away to take something called a symptom history. And we'll discuss what that is and also the value that it brings to patient care. What is the value to that for patients and providers? We're also going to take some time to practice. We're going to do a case study as a group to really practice using the skills that we're going to learn today. And then we'll also look at some examples of various responses that might be available to you when the scope of the call that you're on exceeds your scope of practice as a medical assistant and what your options might be in that circumstance. So let's get started. What are we talking about? No discussion of phone screening would be appropriate without first figuring out what is it. So who would like to take a stab at defining and describing phone screening to me? Any ideas out there? I'm sorry, we gave you food and then asked you questions. Uh-oh. This is going to be a very participative discussion, as long as we participate.
Is it what they're calling about? What the patient's calling about?
Okay, maybe finding out what the patient is calling about. That's part of it, right?
What about priority? Does it go straight to a nurse or does we talk to a doctor?
Okay, maybe determining what to do with the call. That might be a component as well. Why do we do it in the first place? Why might we be doing phone screening? It's okay if you don't have an answer to this question off the top of your head either. What are we trying to accomplish? Do we have a goal in mind?
Oh, what the patient's needs are.
Sure. So we're trying to figure out what's the concern that the patient has, what do they need, and how can we fill that need, right? So, okay, somebody's responding in the question box. So let's actually look at a more formal definition of phone screening. I've lost mine. So it starts with a conversation. So this is pretty obvious, right? We're talking to the patient over the phone. And where it's going to go is determined by the goal and the objective of phone screening, which is systematic collection of information. So we're getting data from the patient, and we're documenting symptoms that may be going on and the history of those symptoms. And then that history is communicated to the provider, who makes an assessment of what that information might mean, determines a disposition, and what advice to give the patient. And then the unlicensed person or medical assistant can also relay that provider's advice to the patient for their plan of care. So we can see there's an interactive process here. We're asking questions, we're getting information, and then we're also doing something with that information. We're communicating it, and that there's some element of timeliness to that we wouldn't want that process to take a very long time to get that response back to the patient either. So how is that different than telephone triage? Because in the past, it might have seemed like, okay, phone screening was just triage reskinned, but that's not necessarily the case. Telephone triage is very similar. It also is a conversation, and it's going to look very similar in some ways because there's still an exchange of information. What the difference is what happens with that information. The goal of telephone triage is to make an assessment of the nature of the problem and the urgency of what to do about it. So triage, the word triage, comes from a French word for sort, and that is exactly what nurses are doing in triage, is sorting patients into categories based on the nature and urgency of their symptoms. And that is within the scope of the nursing license, to make that assessment, and then to lead to advice that's given to the patient, a disposition, referral to an appropriate level of care within that appropriate time frame. And that doesn't mean that the provider is not involved in telephone triage. It just means that the burden is on the nurse to make the decision about when to involve the provider. It's It's their job to know when that needs to happen. So that is really the description of the two, but that can be kind of hard to wrap our heads around sometimes and figure out the difference. So what we've done is provided some diagrams. So you should have a handout. It's titled the telephone triage concept diagram. One side looks like this. This is phone screening depicted with circles, so bubbles, whatever you want to call them. If you want to look at that while you're taking a look at this, if you are on the webinar, you should have received these handouts in PDF form in an email. If not, they should be downloadable from the webinar box. So take a look at those. Now, if you look at this, you can see that the medical assistant is a conduit for information. So they're getting information from the patient, they're bringing it to the provider, and then the provider is giving them information in the form of advice, instructions, plan of care for the patient, which then goes back to the patient. So in both directions, what we want is completeness and accuracy, right? We want to make sure that the information the patient tells us gets to the provider with its full integrity, and then the plan makes it back to the patient with completeness and accuracy, right? Now, telephone triage is a little bit different. Again, still a conversation, still an exchange of information, and that initial conversation may actually look and sound very similar because there's going to be similar questions asked. There's going to be a similar process followed. It's what happens with that information. So the nurse makes an assessment of the nature and urgency, determines a disposition, and gives advice. That's all within the scope of their license. And the provider is still involved, but it's in a consultative role. So again, the nurse is burdened with the decision of deciding when that provider needs to be involved in that care. So the advantage here for you as medical assistants, you don't have to make that decision, because in phone screening, the provider needs to be involved in that decision-making process. So why would we even have two processes to begin with? Why come up with two workflows of how to handle a call where the patient has symptoms or concerns? Well, basically it comes down to scope of practice, right? So we have a question for all of you, and this is not a question we want you guys to answer out loud, but we'd like you to think of an answer to this question. On a scale of 1 to 10, how confident are you that you are personally practicing to an appropriate scope for your level of license? Think about that, and while you're thinking about that, I'm going to hand off to Amanda, who's going to discuss scope of practice.
Hi, guys. So we're just going to ask you guys some questions about, just to really challenge your thinking in regards to this. So I'm going to read it out loud. So after discussing upper respiratory symptoms with a patient, a medical assistant says, "We have no appointments in the office today. You should go to immediate care and get checked out." Do you guys think that's the appropriate scope of practice for this MA? Yes or no?
No.
I think we all agree on no? Okay. Well, the answer is maybe. So it's a little bit of a trick question. So it depends. Did the provider direct and instruct that MA to have the patient go to the immediate care? Because if they did, then that is the appropriate scope of practice. Because like Jared said earlier, the MA cannot make an assessment, right, for this physician, which in this case, that's what that is. Okay. So I have another one. Just another challenge question. So after progressing through the appropriate triage protocol, a registered nurse determines that the disposition recommended by the protocol doesn't quite fit the clinical situation. She states, "I don't have a protocol for this. I'm just going to talk to your doctor and I'll get back to you." Okay. Do you think that's the appropriate scope of practice for the nurse? Yes or no? What do you guys think? Maybe I'll trick you again.
I think yes. Yeah, I think it is.
Okay. So I did trick you again.
Yeah.
So the answer is maybe, okay? So this also depends if she made an assessment. Otherwise, she's not really working up to her scope, right? Because nurses can make an assessment and disposition, right? So it depends if this nurse made an assessment that allows for that delay in speaking with the provider. Okay? So now we kind of saw the differences there in the scope, okay, between the nurse triaging and the MA phone screening. So we'll just take a closer look at, get a little more nitty-gritty with the different scopes. Okay, so one thing I want you to notice here, this is actually a handout. You guys have a handout of this. I'm not quite sure what it's called. I think it's triage and scope. Okay, so if you guys want to follow along with that, you certainly can. But notice that we added clerical here. The reason for that is because they play a big role in this as well, right? They play an important role because they answer the phone call, right? And they determine what the primary concern is of the patient, okay? And then they'll either forward the message to the clinical staff to take a call if it's not urgent, but if it's an emergency, they'll then forward it to a clinical staff without hanging up that phone, right? The MA is a little different, right? They do what's called phone screening. You guys do what's called phone screening, and you obtain the clinical information. But notice here that it says stop, right? That's because the MA can't make an assessment, right? So you obtain all that information, very important information, right? And then you forward it to the provider to review and determine what to do with that, right? And then you then take that information from the provider and relay it to the patient. Okay. Now the nurses are a little bit different. Everyone's a little different in this role. LPNs do what's called supervised triaging. So they can make an assessment, they can disposition the patient, but it does need to be forwarded to the provider for review and final signature. Right? And the RN or nurses, the registered nurses, sorry, are a little different. They do independent triage, so they can assess, make a disposition, and also they don't need a final signature from the provider. Some do, and that's okay, but it's not needed because it's within their scope. Okay. So I'm going to hand off this to Lisa, and we're going to go through some case studies and where you can apply this information.
Thank you. So we wanted to give you a little bit more context to this, all these words here. So what we're going to do is we have a couple audio clips that I'm going to play, and what I'm going to ask you is this within the medical assistant scope of practice or not? Okay? All right. So here's the first one.
Oh, this is Foundation Medical. This is Greg, medical assistant speaking. Hi, this is Alan. I'm calling because CVS didn't get my prescription, and I need those pills for my blood pressure. Oh, okay. So I can actually see here that it was sent in yesterday. But I don't understand this. I've been taking this medication for years, and I've never had a problem like this. And on top of that, just this week I've been having these dizzy spells, and my heart sounds like it's skipping a beat. Okay, well, I'm happy to follow up on the prescription refill, but I'm concerned about the dizziness you're having. Are you having that right now? Yeah, and my heart feels like it's pounding out of my chest. That's why I really need these pills. Oh, I think it would be best if you spoke with our triage nurse. Let me transfer your call.
What do we think? Should that be within the scope of a medical assistant or out of the scope? Within. Yeah, that one's within the scope, okay? Because we have what is potentially an urgent phone call. We don't know if it's urgent yet, right? So we would want to, the best way to handle that is to really push that call off to a licensed personnel. What if your nurse isn't available, your licensed personnel isn't available in your practice? Then we would want to get the provider involved, right? What if the provider's not involved? Or what if the provider's not available?
That would be impossible.
Yeah, typically, in an ideal sense, your practice should have some sort of a procedure set out for that instance. So we want to come together as a practice with your manager to determine that procedure. Okay? All right. Let's move on to the next one.
Hello? Hi, Mr. Brady? Yeah, that's me. Hi, this is Jan. I'm the medical assistant for Foundation. I'm calling with some results. Can you confirm the date of birth? Oh, sure. It's March 15th, 1970. Great, thanks. I think your ankle x-ray came back normal, so no fractures. Really? I could have sworn that thing was broken. It's still swollen. It's killing me. That's too bad. Well, usually Dr. Bobby recommends ibuprofen. Maybe you could try that and see if it helps. Oh, yeah, I guess I'll try that.
What do we think about this call?
Yeah.
Right.
Advice.
Exactly. So we're providing advice, which it actually could be outside of the scope of the licensed personnel also. However, there's a caveat to that. The protocol book, if it's in the protocol book, then the licensed personnel may use that for advice, okay? But in a general sense, that would be out of the scope, okay? I'm just going to switch back to number 2. I got a little sticky with this button here. Let's see if we can do that. There we go. I have to go back one more. There we go. Figured
Hello? Hi, is this Marsha? Yes. Oh, hi, Marsha. This is Peter from Foundation Medical. I'm calling with some lab results. Are you able to confirm your date of birth for me? Oh, sure. It's January 1st, 1940. Oh, thank you. The doctor wanted me to let you know that your urine culture results came back normal. Oh, really? Shouldn't my symptoms be cleared up by now then? I'm drinking loads of water and still feel the burning. Oh, no, you really shouldn't be having symptoms anymore. Why don't you go to immediate care? Because we don't have any appointments today, and you really should be seen.
All right, what do we think about that one? In scope or outside of scope?
Maybe.
What do you think?
I think providing the right answer for all providers, get them in.
Maybe.
Yeah.
Or
So
at least see if we can do what the provider wants to do. So it's one of those, yeah.
yeah, so that with the nature of the call itself, just based on the call, this would be outside of the scope because we're independently providing advice in a disposition. So we wouldn't be doing that, okay? So I'm gonna go ahead and hand it back over to Jared, who is gonna talk about phone screening success. There we go. All set.
Thanks, Lisa and Amanda. So we've kind of established at this point that we know what phone screening is, we know what telephone triage is, we understand that they're different and that there's reasons for that based on scope of practice. So that's well and good, but we'd like to know how to actually be good at this and how to develop the skills that we need to succeed at phone screening. So to introduce that idea, I want you to think back to the last conversation or last few conversations you've had with patients over the phone. And think about this, when you're discussing symptoms with a patient over the phone, how do you know when you have enough information? What kind of tells you that as you go through that conversation?
Well, if I take a call that turns into a triage, I have protocol book right there.
Okay, how many of us are using the protocol book when we talk to patients over the phone with symptoms? Okay, that's not wrong. We're not going to tell you to stop doing that. But we are going to discuss some caveats to using the protocol book as a medical assistant in a moment. Now, this is a challenging question even for nurses to answer. So this is not something we're expecting, again, for you to have an answer off the top of your head. What do you do, though, when there is no protocol for the situation?
I just ask them, is that, do you have anything else that you want me to add to this note? And they say no, then I just triage them, well, I'll send it over.
Okay, yeah, we can rely on the patient to some extent. If they can give us, at some point they're going to be done talking, and they're going to at some point run out of things to say. So that's a useful thing. Is there anything else you'd like me to help with, or something like that? So these are good questions to think about in terms of, okay, how do I know that I'm getting a complete history? Because remember, that was one of our goals. So let's actually look at a scenario that's sort of similar to what you might see in practice. So let's say you call a patient to discuss normal lab results. And in the course of that phone call, after you've already talked about the lab results, the patient's like, I've been meaning to call you guys because I've been having these headaches. And I don't know what to do. Should I book an appointment? Or, I don't know, maybe there's something I could be doing right now at home. What do you think? As a medical assistant, what's your goal in this conversation?
Information.
Okay, I heard a couple different things there. I heard gather information and maybe talk to the provider about what to do next, okay? And that's what we want to kind of focus on, is what's the goal? So to emphasize the importance of our goal in phone screening, we're going to read a little vignette, a little story, and I want you to pay attention to what is missing or incomplete from that initial conversation with the patient. Please ignore the scope of practice issues with this story, okay? Just focus on what's missing from that initial conversation, and Lisa is going to read that.
Thanks. An elderly gentleman visited an urgent care clinic for evaluation and treatment of gout, for which he was placed on indomethacin. He took his first dose that evening and his second dose the next morning. Shortly thereafter, he began vomiting and called the urgent care clinic to inquire about what he should do. DMA, assuming the problem might have been related to the indomethacin, asked him if he had eaten breakfast before taking his morning dose, which he had not. Assuming the patient's GI upset was related to indomethacin, she advised the patient that indomethacin can be hard on the stomach and to be sure to eat before he took his next dose. He then inquired about what he should do for the associated pain in his throat, for which the MA recommended acetaminophen, once again assuming the throat pain was related to the vomiting. The patient was dead 1 hour later, secondary to an anaphylactic reaction to indomethacin.
Wow.
Okay, so, yes, extreme example.
Wow.
Yeah. Not all your patients are going to die 1 hour later. But what was missing from that initial conversation?
There was no consult, the provider or nurse or anything
Okay.
like that.
Yep. So again, try to ignore the scope of practice issues. Obviously, there's quite a few in this story. But what did maybe we not do in the initial
Well, the
conversation?
assumption was that everything's related to the indomethacin. There was no other information gathered, right?
Yeah. So there's a lot of assuming. So when there's assumptions, what are we not doing?
We're not getting a complete story.
Right. We didn't get a history from the patient. We didn't gather enough information. Because if we had the right information, regardless of who's making the decision, it makes a very different story when we have more information than just, oh yeah, I took the indomethacin and I vomited later. There's more to that story that wasn't obtained in that initial conversation. So just remember that when you are on the phone with patients and doing phone screening, it's all about the data that you get from the patient. So while you may not make an assessment or a disposition as a medical assistant, you can always take a high-quality history of the symptom. That is absolutely within your scope of practice, and the skills and principles that are required to take a good history are the same whether you're a doctor, a nurse, or a medical assistant. It's the same skills, and we all can always get better at that. So that's what we're going to focus on today, is how do we take a good, complete, and coherent history from the patient, because this makes a huge difference for providers. It enhances their decision-making when they can see the picture and they have complete information. And of course, when that happens consistently, they're more satisfied with your performance, and that makes your day better, right? When you know that your provider has confidence in you because they see that consistent result. It also improves the efficiency of care and the service for the patient, so then the patients are happy with you. I don't know about you, but when the patients are happy with me and the providers are happy with me, I'm having a good day, right? It's definitely a better day than if the providers are not happy with me and the patients aren't happy with me. So that's something that definitely makes a difference for you. Now, this is one opinion from one of our primary care providers in the organization. She says a full, clear, and concise history provides the necessary information for the provider to make a clear assessment and determine appropriate disposition and treatment recommendations. It's also critical to workflow for a practice, as multiple callbacks to gather information delay response and care for the patient, as well as requiring additional time on behalf of the MA and provider team members. So I know this is only one person's opinion, but I've had a number of conversations with numerous providers in our organization, and many of them feel similarly, that having better information, whether it's a nurse or a medical assistant doing the initial talk with the patient, makes a huge difference in the outcome for the patient and in the efficiency of care. So, okay, we get it. It's important. But how do we do it? How do we actually go about taking a history? Well, how many of you, when you talk to patients, get a nice, clear, organized, coherent story? Yeah, right. Almost never, right? Because it's just like it's verbal vomit. It all comes out, and it's not organized because they're just telling you what they remember. And as a professional, it's our job to organize and complete that history to make sure that it creates a clinical picture. So how do we do that? Well, there's some proven success strategies and tools out there. Some of the tools we commonly use are mnemonics. We're going to give you two options that you can learn. We'll look at them in a moment, but that's going to be used as a mental checklist. So while the patient is talking to you, you go back to this mental checklist to see, okay, what are the categories of information that I need to make sure I have? And how do I clarify it further? Do I have sufficient detail to wrap up this history? So there's going to be two different things here. You don't need to use both of them or memorize both of them. We're giving you two options because, as you can see, these two words, old carts and phosphate, are the same ideas organized a little bit differently. So each of these words has, each of those letters in the word stands for a category of information that you're going to want to gather from your patient while you talk to them on the phone. So you'll notice that phosphate organizes things in a little bit of a different order than old carts, and it combines some of the ideas in old carts into a different category. So whichever one of these makes more sense to you or is easier to remember, Pick one and get good at it. Just practice it. Personally, I use old cards because that was what I was taught. It's what I'm comfortable with. It's sort of second nature to me now. So let's walk through that one thing at a time, and just remember that these are the same ideas. So we'll walk through one of them with the idea that they do cover the same information. So the O stands for onset, which essentially is about when and how the symptom began. So when did the symptom begin? We want to be as specific about that. What's the date or time that it began? How did it begin? Is it gradual or sudden? Is it something that comes and goes? Those are important details. The location, what part of the body is affected, and is it always in the same location? Does it move around? Is it migratory or radiating? Those are important details, right? Doesn't always apply to every single symptom, but it's good information to be thinking about, especially when you're on the phone with a patient and you're like, oh, you know what, you told me your leg hurts, but you didn't tell me which one. That's important information, right? And sometimes when you're in a hurry, it's hard to remember those things. So duration, the D, stands for how long does that symptom last. So this could be different depending on how the symptom is occurring. If it's something that has been continuous, you're looking at the total amount of time. If it's something that comes and goes, you want to look at how long does each episode last. What's the longest amount of time it's happened for, the shortest amount of time. Those are important details there as well. Characteristics. This is about how to describe the symptoms. So we're pretty comfortable with asking patients to describe their pain. So for instance, is it sharp pain or dull pain? That's a characteristic. Another example of this would be if there was, like, say, a cough. A cough can be productive or non-productive. Those are characteristics. The A stands for two things, actually, which is a little misleading, but it's aggravating and alleviating factors. That means things that make the symptom worse, things that make the symptom better. There's a little overlap with another category here, but these are the types of things that might worsen or lessen the symptom. The R stands for related symptoms. Now that is meant to be an open-ended questioning to determine if anything else is happening at the same time. So you might ask that patient with headaches, when you get a headache, is anything else happening that bothers you at that point in time? They might come back with, every time I get a headache, I get nauseous. That's important information. It changes the story. It also helps to make sure that we're focusing on the right symptom, because sometimes the first thing the patient tells us about isn't the most important thing they're going to tell us, right? They might tell us that, I've been really tired lately, and then later they're like, I've been having chest pain every day when I walk up the stairs. Totally different story, right? But if we never ask that question, we never get to that point. So those are important things, right? Treatments is, okay, that seems pretty obvious. What have they done to treat it? So that includes any home remedies they've tried, any over-the-counter medications they've tried. Do they have prescription treatments that they're using? Are they using them? Are they using them correctly? Also, are they working? If you're trying to treat it, is the treatment doing anything? That's really valuable information for the provider. Think of the opposite. If we never asked about treatments and the patient's already tried something and the provider comes back with, you should try this thing that you've already tried and didn't work, right? That's kind of wasting everybody's time, right? So we can see the completeness and the efficiency coming together. The last letter, S, stands for severity. So we're pretty comfortable with this with things like pain, where we can say, okay, give me a 1 to 10 scale or a 0 to 10 scale. That gives me an idea of the severity. Not everything will fit into that box, though, of give me a 0 to 10 scale. So how do we determine severity for some of those other kind of harder to figure out symptoms? We use something called a functional impact. Does anybody want to take a stab at what that is? What do I mean by functional impact?
Are they able to go about their normal daily activities?
Nailed it. Right. So what is the impact on their daily life? So what are you not able to do today that you normally can do because of this symptom? That is critical information for the providers. Makes a huge difference in really seeing the severity of the symptom and what it's doing to the patient. So those are really important things. So what about the protocol books, though? Because, this is cool, but how does it fit in with the protocol book that gives me a bunch of questions to ask? Is it replacing that? It doesn't. They actually work together, and the way that's going to work is that you want to actually take your symptom history before you even refer to a protocol. If you're using a protocol as a medical assistant, which you certainly can do, it's important to remember how they're intended to be used. Protocols, even for nurses, are meant to prevent you from forgetting important information. It's not meant to guide you through the history of the symptom. The history should be taken before you even open that book, because you may not even be on the right page if you don't know what's actually happened, right? You'll also find that it's more efficient this way, because by the time you have completed this process of going through this mental checklist, getting all the relevant categories of information, you're going to have already answered a third to maybe a half of those questions in the protocol, and you can just skip over those. You already know the answer to those. You're going to ask the questions that you have not already answered, and that is going to make it more efficient. Now, if you are using protocols as a medical assistant, you have to also keep in mind that those are designed for nurses who have the license to make decisions. So there's a bunch of information in there that's really not going to be something you're using. So don't get stuck down the rabbit hole of giving the patient advice or making a disposition just because it's there on the page. Also, this is a useful clue to you. If you find that the triage protocol is sorting that patient into a more urgent category, that might be a cue to grab a nurse and get them on that call, and maybe make a more detailed assessment of the patient. So that's something to think about. And just remember that you can use that protocol for the questions and to help complete your history, absolutely. But just remember where the limitations are with your scope, so that you're using the tool effectively. So the process is do that symptom history, use that mnemonic to put together the picture first, then bring in that protocol to kind of fill in the gaps and make sure that there's nothing else going on that's important. So this is an interesting process, an interesting skill, but it doesn't really help you unless you have some time to practice. So we're going to switch over into a case study, and Amanda's going to run the case study. And this is going to be typical of something you might see in practice.
Thank you, Darren. So we're going to apply those mnemonics that you just learned to a case study regarding Mike. So this is Mike. Might look a lot like Jared Karen, but he's Mike. In the spirit of sticking with the Brady Bunch names, I don't know if you guys have noticed, we're going to call him Mike, okay? So Mike is 43 years old. He doesn't take any medication. He doesn't take any medication. He has no allergies, and he has no significant past medical history. He's either the perfect patient or he hasn't seen a provider in 10 years, right? So the phone note states that he's been complaining of a cough. So how am I going to initiate this conversation with the patient, with Mike?
Quick timeout from our scenario. I'm not Mike right now. Just for the benefit of those on the webinar, if you could please just raise your hand. We'd like to get one response at a time, just so everybody can hear what's said. So carry on.
Thank you, Jared. I forgot that. Okay, so how would we initiate this conversation with Mike? We need some participation. I want to see lots of hands.
I would introduce myself and confirm his date of birth, and then first I'd ask him how long he's had this cough.
Okay. So you probably want to ask him some sort of general type of question to sort of start the conversation. Maybe like, tell me what's been going on regarding your cough. So exactly, absolutely. So we've asked him what's been going on, and he says,
yeah, I've been coughing nonstop for like over a week now. I was wondering if Dr. Brady could call in a prescription for me.
Okay. So we want to use our handout with the old carts and phosphate, and let's just sort of follow old carts. I'm personally a little more comfy with old carts, and we've already used it today. So why don't we stick with old carts? And what else are we going to ask Mike? Okay, so when did it start?
So it wasn't this weekend. It was more like last weekend, like somewhere between Saturday and Sunday.
Of course, right?
Not really sure, but that was kind of like.
Of course. So maybe we'd want to ask him a little more details on that. We really want to try to get the date and the time, but a lot of times we get that, right? So maybe we want to investigate a little further with that. So what else would we want to ask him? So we're following our old cards?
Well, obviously location, but I would ask, is it like a deep chesty cough, or is it more of like feeling there's something in the back of your throat?
That's a good question. That's a good question. And sometimes location might not necessarily be helpful.
Yeah.
Right? When you have a cough, maybe it's not super helpful. We know the cough comes from your chest and your lungs, right? But I like that though. I like that a lot. So certainly we could ask that. That'd be helpful because maybe it's just more postnasal in the throat rather than a cough, right?
It's kind of like a dry hacking cough. That's how I would describe it.
Okay.
I'm not coughing anything out though.
So what else would we want to ask him? So dry hacking cough. It's, he wasn't very descriptive on the onset.
Any other symptoms that you're having? Any runny nose, postnasal drip?
Well, I don't know, I get these coughing fits, and in the middle of that, it feels like I can't really catch my breath while I'm coughing like that. That doesn't happen all the time, though.
He's just so easy, right? It doesn't happen all the time. So, right, like you said, shortness of breath. Very good. So what else would we want to ask?
What remedies have you tried and taken?
Yep.
I don't know, I found this stuff in my cabinet, and I didn't know what it was. It had an orange box. I think it was called Delsum. And so I took a swig of that. It didn't do anything.
So that orange box. Okay, thank you. Mike. So that orange box he took. So we've kind of hit on onset, location, related symptoms, sort of, and then treatment, right? So is there anything else we're missing here?
Well, I would ask, does anything make the cough worse? For example, does sleeping or laying down make the cough worse?
Very good. Yep.
Does being outside in the cold make the cough worse? Does anything make the cough better?
Very good.
Are you a smoker?
Yeah.
Yep, that applies, absolutely.
Have you traveled recently?
Good question. TB, right? You're thinking TB maybe? I like that.
On a plane?
So it definitely gets worse when I lie down. I haven't figured out anything that helps it, and I'm not sleeping very well at night. So,
Are you having any nasal congestion? Any sore throat, headache, ear pain?
nope, none of those things.
Okay, so that would go under the related symptoms, right? What else are we missing here? There's one kind of in the middle there that we sort of jumped around a little bit.
Characteristics?
Yes. So what would we ask about a cough?
Well,
That's
you
a
said
good
it's a
description.
dry. You said dry hacking.
Dry.
Yep, he did say it's dry. That's right. I'm sorry, he did put that in. You're right. So it is dry. So the question is, did he cough anything up? If he did, what color is it? Is it green, yellow? Right. Yep, absolutely. So, yep, I apologize for that. And what else?
Do you feel like it's getting worse? Are you able to go about your normal daily activities okay?
It's really tough to go to work because I'm not sleeping. So,
Okay. So it's impacting his daily activities, right? So that goes under severity, functional impact.
can't the doctor just call an antibiotic?
No. So I think we have a pretty good picture here, right? Do you guys agree?
Yes.
Okay, I agree. We kind of hit on everything here as far as old cards goes. And again, as long as you're using one or the other, old cards or phosphate, one or the other. But this is kind of a comparison slide here. So we're sort of shifting a little bit. So this is the information on the left that we started with, right? He has a cough, and he just wants his antibiotic. Right? That's all he wants. He doesn't want to talk to anyone. He just wants his antibiotics. But which is more helpful for the provider to make a decision or come up with some sort of plan for this patient? All the information that we have here on the left, or all the information we have here on the right? On the right, right? We have a lot more information. So this is what we started with, cough, and basically went through prescription, right? Now we have 10-day history of non-productive hacking cough, gradual onset, worse at night and with laying down, associated shortness of breath with coughing fits only, tried over-the-counter Delsum, that orange box, right, with no significant effect. Cough is impacting sleep and work performance. Patient is requesting antibiotics. So much more valuable to have a good symptom history, right? So you guys did that. So good job. Awesome job. So I'm just going to pass over the remote to Jared again, and he's just going to tie things up.
Awesome. Thank you, Amanda. So even though we've kind of had a really narrow focus today and focused on one aspect of phone screening. We have covered a lot of ground, so I do want to wrap up a few of the takeaway points. First of all, remember that phone screening is that interactive conversation with the patient, and we have some goals. We want to collect a systematic history of the symptoms, document that, and have timely communication with providers for the disposition and advice to the patient. Remember that licensed nurses perform telephone triage by making an assessment of the patient and determining a disposition, and that LPNs require supervision in that process by means of a provider final signature. And then remember that successful phone screening starts with good history taking, and those skills are the same whether you're a medical assistant, a nurse, a doctor, nurse practitioner, any of those people. It's about how we ask questions, how we organize that conversation with the patient. So what are you going to do when you go back? How can you get better at phone screening? Have your goal to collect that accurate and complete history of the patient's symptoms when you're phone screening. And then practice using those mnemonics. Pick one, old carts or phosphate, and work on using it as that mental checklist as you go through that conversation with the patient. Remember, you can use protocol questions to help you complete your history, but that shouldn't be what's guiding you through the conversation with the patient. But avoid selecting a disposition, remembering that that is outside of your scope of practice or dispensing advice. So just keep those lines nice and clean for yourself and for your providers. So we did mention that we're going to be bringing more content next year. So as a preview of that, what's coming next is a deeper dive into protocols. So we want to look into what that role of the protocol is, how to select the appropriate one, and then how to use them effectively and really read what's on the page. So that's coming in 2019. Stay tuned for that. There will be some specific content for you as medical assistants because, again, the scope is different. So what you're looking at on the page is going to be different than what a nurse is going to look at. So we want to get you excited about that because it's coming soon. These are our references. And one last word about your contact hour. This is your last chance to write down the evaluation link. You might want to do that or snap a photo of this slide. Remember that you will need to sign in, attend the session, and then complete that evaluation online by the deadline. When we receive your evaluation, we're going to have that sent to you somehow. If you have questions about this process, please reach out to our project manager, Julie Sampson, who will assist you in that matter. We have a few minutes if anybody has questions about the content.